Hi, everyone. I'm hoping I'm recording. I just clicked recording, so I'm hoping it's doing that. I am excited to be finishing off our cardiac lecture, but boy, I wish I was with you again. This is such an exciting topic. We've covered a lot. You know a lot. It's really important that we understand the commonalities when we look at these different conditions and also the differences in our approach. So let's move forward. And if you remember, this is the last slide we looked at. Remarkably, we're looking at these two areas. Now, I don't know if you can see my, my arrow. The one arrow with the white area, that is a full thickness MI. You see that tissue is all, we've got lack of oxygenation to that tissue because of lack of blood flow, and that leads to cellular death. And there you see that it's all turned white, and we see that deterioration. Over here in this area, it's interesting. That's evidence of a previous MI, where you see this smaller area where there is tissue damage, permanent tissue death, because we don't have that nice red area to show us that we have good oxygenation, good blood flow. But because it's not full thickness, the patient probably survived that MI, has gone on and had a second MI, which we know is one of the very significant risks in association with having an MI, right? That you'll have a recurrence. Goodness me. And again, we're going to look here. So remember, when we're thinking of full thickness, it is that full muscle layer thickness, right? So then you have an MI can occur in any part of the heart. That different. We typically identify an MI by its location. So anterior, posterior. So it's at the back of the heart. Inferior. Sometimes it'll be lateral or anterior lateral. So anterolateral. So it depends, the cardiogram, depending on, remember I told you the pattern of elevations that we see, if it's a STEMI, in particular that ST wave elevation, will tell us about the location of that MI. We also do an echocardiogram, which really looks at the functioning of the heart, and it tells us about the contraction of that heart, because if we have that damage, where the muscle is impeded in its ability to contract. Okay, so what is the story on an MI? My gosh. Almost all MIs, 70 or 80 to 90% of all acute MIs are secondary to thrombus formation. And you met thrombus means a clot. So we've got a clot formation that occurs. We have that lack of blood flow. The tissue becomes what we call ischemic. So on a cardiogram, remember I showed you on that strip on the board that we can have an ST segment depression and even a flip T wave. So instead of going upwards, the T wave goes downwards, but that ST segment depression, which is not an MI because that's elevation, but it's actually ischemia, which means it's not permanent cellular death, but it is a lack of oxygenation to the area. We begin with that ischemic, and the first area of the heart is actually that subendocardium, right? The innermost layer of that of the cardiac muscle. And if that persists within 4 to 6 hours, that can spread to the entire thickness of the heart muscle, and that becomes necrotic or necrosed. So remember, we saw that picture with that whole white section. And again, we usually describe them in relation to the area that they're located. When we see that ischemia, we want to respond really quickly, because within 20 minutes of that beginning of that ischemia, we can cause irreversible myocardial cell death. And remember, what that ischemia represents is a lack of oxygen to that part of the heart, and the lack of oxygen occurs because of the lack of blood flow and the inability of the oxygen to cross through those membranes. Okay, so when we look at clinical manifestations, really important that we're able to recognize these, right? And the degree of altered function that we see with an MI is often dependent on the location of the MI. So not every MI is the same in terms of the significance of the MI, in terms of how widespread it is, in terms of the consequence. One of the things we already talked about in class was, if you're younger, you may not have developed that collateral circulation. If you're older, you may have an MI in one area, one blood vessel may be blocked, but you may have other vessels that allow blood to flow past that blockage. Also, we know that we talked about this in class, that left ventricle is the big powerhouse pumping muscle of the heart. And so that plays a really significant clinical function for your heart to be able to pump blood out through your body. So an MI that represents an area that has a really significant role is important. Also, if we have an MI in an area where the electrical system is powerfully impacted, and remember that's that SA node to AV node down through that bundle of His and Purkinje, all the way up through those Purkinje fibers. When the electrical system is really impacted by the location of the MI, that can have a real impact. And so important to look at these manifestations. Pain, cardiac pain is different. We talked about that already. It can be center. You can say classic. Feels like an elephant is sitting on my chest. You can have no pain at all, but just have sweating and nausea. So it's a huge gamut. You can have pain left arm, left jaw. For women, often there can be right arm pain. We can have pain just in the back. Some people just have that feeling of epigastric upset or epigastric burning. So often you'll find patients come in with an MI having first tried something for like upset stomach or Tums or Rolaids, thinking maybe they've just got some indigestion. We also see that you have sympathetic nervous system stimulation. So when we have that sympathetic nervous stimulation, remember that's like that fight or flight, you can have tachycardia, your heart rate is going to increase, you can have sweating, you can have that feeling of agitation, and often that feeling of impending doom that happens with that. We see all kinds of cardiovascular manifestations. They can be related to that inability of that heart muscle to pump as effectively. So you can have a decrease in blood pressure and a decrease in your level of awareness because you're not pumping blood as actively through your entire circulatory system as you otherwise might. We can see those, we talked about those dysrhythmias, or you'll see the word arrhythmias. Arrhythmias is not exactly correct, but you see it equally, and so either are fine. I wouldn't get myself concerned if you saw dysrhythmia or arrhythmia, and those are related again to that, the impact of that cellular death around the electrical conduction system, and or when you move to that anaerobic, so lack of oxygen, metabolism in certain areas, the excitability of that electric cardiac conduction system can be impacted. You can have cells just all trying to jump in and be the leader instead of the SA node, and all kinds of things happening. Very frequently, we're going to see nausea and vomiting. Patients, often you see that ashen skin, they're clammy, they're cool to touch. They have a rapid heart rate. Blood pressure can be at first elevated, and then it can drop secondary to that decrease in cardiac output. Because of that sympathetic nervous system stimulation, you may see a release of glycogen, and when you have that release of glycogen, you can have an elevated blood sugar. That's not going to mean you have diabetes, but in a stressful situation, your body releases that so that you can mobilize as much as you may need to. And you can have fever, anomalous fever, again, that sympathetic response. You also can see sometimes crackles in the lungs, so a buildup of fluid. We're going to talk a little bit about heart failure, but when your heart is not pumping effectively, you can see that backup of fluid, in particular, some crackles in your lungs, and that jugular venous distension. I know you learned about that in health assessment. And I'm not getting too hung up on this, remember, but normally lub-dub, when we listen to a heart, is S1, S2. In this case, we may hear S3 and S4, which are really different kinds of heart sounds that tell us about our heart and our valves not working efficiently, and often related to some fluid overload or some other process there. In this, shall I tell you about this picture? So here we see, do you see in right up here, we've got in AVR here, we've got an elevated ST segment and a flip T. Let's see. And over here as well, we've got an elevated ST segment, and over here. So, and here. So here's where we're looking for the patterns of leads to see where we're going to find our MI, and keeping in mind, and you don't need to memorize this, this is just a point. If I was only on a cardiac monitor, which is typically lead 2, not doing a 12 lead ECG, On lead 2, that's over here, there is not ST segment elevation. There's nothing going on with my T wave because lead 2, the picture that lead 2 shows, the angle that lead 2 shows does not show the area of injury. All right, important that we recognize when we are doing a diagnostic tests and why. And so we talked about this in class. There's 3 particular markers. These markers are important. These serum cardiac markers are really important because they tell us about what's going on with the person, and they rise at different levels. The marker that is most specific is troponin, most specific to cardiac cell damage. All of them reflect muscle damage, but they can reflect all kinds of different muscle damage. Great muscle damage, let's say you bang yourself in a car accident, bang up your legs and other places. Your CKMB would rise, your myoglobin would rise, but it's your troponin that is very specific to cardiac cells. But the reason we don't only do troponin is because first of all, it's not the first one to rise. We're going to see a rise in our myoglobin before we see the rise in the troponin, so that would be indicative, and it's just more information. So within hours, we're going to see that rise. Within 1 to 2 hours, we're definitely going to see that rise in troponin. That's going to be really important. We want an electrocardiogram, so a 12-lead electrocardiogram that's going to show us a pattern of changes reflective of an MI, which would be that if we're talking about a STEMI, remember the ST segment elevation. And we're also, interestingly, going to look at a white blood cell count. And the reason we see that is because macrophages are released to remove that necrotic tissue. So that elevation in white blood cell count is actually indicative of a underlying process. So what kinds of complications do we see as a result of an MI? Number 1, it's that looking at those dysrhythmias. And do you remember that we get what's called aberrant or unusual conduction? So there may be damage to a part of the conduction pathway. We may have a process that's happening when we go to that anaerobic metabolism, that some of the cells are just acting out in other areas of the heart, and they want to jump in and become the leader, and they are impeding the ability of that SA node to be the leader, and other cells may become quite excitable, and so they'll put you into all kinds of different rhythms and take over leading the electrical process in a pathological way. So dysrhythmias, very common, in particular in the first 8 hours. The most common thing we're going to see are those dysrhythmias. And within the first 24 hours, it's not uncommon to see lethal dysrhythmia. So we really pay attention to that, really pay attention to that. We're looking for heart failure. We're going to talk about that a little bit more, but that heart failure, which can be left failure or right failure or combined. And so we're going to be assessing peripheral edema, and we're always going to be looking at listening to our patient's lungs, seeing if we can hear any fluid collecting. Cardiogenic shock is a particular kind of shock. It's a really devastating kind of shock, hard to treat. There is a very significant death rate associated with cardiogenic shock, even if it's recognized and treated accurately, because it really represents that the heart muscle is unable to pump efficiently enough to get adequate cardiac output. So your blood pressure is going to drop. You may have a high heart rate. As your heart rate goes up, trying to accommodate, respond to this low blood pressure, you would normally want to give fluid and other things, but your heart is not able to pump efficiently. So if we give you that fluid, we'll put you into catastrophic heart failure. And as your heart rate goes up and your heart is trying to pump, it also increases the oxygen demand, but the primary problem is you're not getting oxygen to all of your heart in the first place. So it becomes a cycle, or sort of a self-defeating cycle. It's very, very catastrophic. So we watch for that and do whatever we can in terms of medications. We give medications to increase the efficiency of your heart rate and manage your blood pressure if we can, and increase the contractility of your heart. Ventricular aneurysm, I'll just talk about that for a second. It's very common that we would see that breakdown of the wall between the ventricles and beyond. Pericarditis is an inflammation that we have around our heart. And remember, think of this process. Your heart has undergone a very significant trauma, that injury related to that lack of oxygen in a particular area and cellular death. And so that process can extend. We can have fluid and inflammation outside of the heart muscle within that sac, and patients are at quite significant risk for death with pericarditis. We also see there's something called a Dressler syndrome, which is a kind of pericarditis when you in particular see injury to the pericardium. So that's the outer lining of your heart. And there we see pain, a kind of like a pleuritic pain. We see fever, and we'll see what's called a pericardial, so around your heart effusion. And that's, again, very difficult to treat. The most common, the most important ones I'm going to say just to pay attention to, although of course you should know them all for life, would be that idea of dysrhythmias, that excitability, the interference with the pathways, incredibly common, particularly first 8 hours to 24 hours. Heart failure, incredibly common, and then moving down these other, quite catastrophic cardiac events. Okay, so how do we move through healing? It's critical that our heart develop those collateral circulation processes. So where we have areas of poor circulation, we can move to being able to provide that blood flow. When we look at the ECG changes, and also if we do some nuclear scans, we can see the actual areas where there is necrosis. And within 10 days to 14 days, this, again, how can the human body be so magnificent? There is a scar tissue forming, but it's also important to recognize that even though you see that scar tissue 10 to 14 days, it's still quite weak, and the person is at real risk for having either an extension of that MA or recurrence of that MI because of stress. I don't mean, it may be emotional or psychological stress, because that does have physiological consequences, but also stress from too much physical activity and other kinds of things, right? By 6 weeks, we've got scar tissue has replaced that necrotic tissue. Remember that picture, that quite graphic, photographic picture of the heart where we saw the new MI that was full thickness, but there was an old MI where we saw that white area that wasn't full thickness. We'll see that necrotic tissue replaced with scar tissue, and that part of your heart is then healed, but it's never as compliant. Compliant means it can actually move, it can stretch, it can expand when it fills with blood, and it can contract well. It's never as stretchy and contracty. It never can move as well, and so we say that's not as compliant. It's like a balloon that has something on it that makes it hard so you can't stretch it. Let's see, what else can we talk about? Oh my gosh, of course, nursing care. So if we, depending on the situation that the patient finds themselves in, we may have to do percutaneous coronary intervention. And that means we're actually going to take a catheter, ensure that that catheter moves through a central vein, femoral vein typically, or a central line. And we're able to actually see where we can visualize where that clot is and actually break that clot down or put in a stent. We can use that fibrinolytic therapy. We talked about that in class. Important to recognize when we give it, when we don't give it. There's a time period under which we can give that therapy, and we talked about that already. And the reason we give it only within that window is that if there is a period longer than the initial treatment protocol, the risk starts to become higher than the benefits. If it's been too long, the risk associated with giving those clot busting drugs, the risk for bleeding in particular, as opposed to the risks now from your MI. And also important to recognize when we're giving those medications, they can either be given, in Canada we give a medication called TNK, in the United States they can give a variety of medications, and around the world. But those clot busting drugs can either be given as a bolus or they can be given over 30 to 90 minutes typically. We can do coronary surgery, and in that revascularization in particular, we would do something I bet you've all heard of, which is called a CABG, or a coronary artery bypass graft. And in doing that coronary artery bypass graft, what we're actually doing is taking an artery, and I'll talk to you about that in a second, and replacing it, putting it in the heart so that we're actually creating that collateral circulation that hadn't developed on its own. We're now remarkably doing a whole bunch of minimally invasive things, including off-pump coronary artery bypass and robot-assisted surgery, amazing. And now we're doing this transmyocardial laser revascularization. We're actually able to use a laser to help move through that process. So I'm not even going to worry about this for just, I am. Let's just talk about what would be the contraindications to giving those clot busters, those thrombolytics, right? If you'd ever had a stroke, in particular a hemorrhagic stroke, right? If you have a known neoplasm, so a cancer, or a intracranial malformation. If you've had an ischemic stroke, so that's not a hemorrhagic stroke, it's not a stroke that's a bleed, but it's a stroke that was formed by a clot, but if you've had that in less than 3 months, if there is a suspected dissection with your heart attack, so you're having aortic dissection possibly, you've had surgery recently. Those are absolute contraindications, although the surgery could be little or not, you know, we're not going to trick you on that, but just so you put it in a little bracketed category in your own mind. Recent head trauma, let's say you had a heart attack, fell off a ladder, had a head trauma, that again, because your brain, the risk is a stroke and the risk for brain bleeding is very high. And if you have bleeding problems, so let's say you have some kind of disorder that causes you to bleed. Relative contraindications, that means not a complete contraindications. If you're over 75 years, I would say that's really relative, and it all depends on how well the person is and how they're living life and other things. If you're already on anticoagulants, again, just relative, you'd have to watch for that. Pregnancy, again, I'm gonna say relative. It's all about save the mom, save the baby, what's gonna happen, and what is the complication of the MI. Hopefully that's not something that you're going to see. If we had to do CPR for more than 10 minutes because of the risk of trauma, so that again, I'm going to say relative, but CPR for more than 10 minutes. If in the last 2 to 4 weeks you've had an internal bleed somehow, again, the risk is you're going to start bleeding again. If your blood pressure is so high, it's uncontrolled. If you've had an ischemic stroke, remember the first one is an absolute contraindication. Ischemic, remember it's a clot, not a hemorrhage. If you had an ischemic stroke less than 3 months, it's an absolute contraindication. If it's more than 3 months, it's a relative contraindication. So anytime in the past, it's a relative contraindication, and also major surgery within the last 3 weeks. Okay, and here you're gonna see this angioplasty. Remember where you, let's say we've tried to give thrombolytics and it's not helpful, or we can't get to the location, where we've actually catheterized the vein. We're right into here, into the coronary artery, and we're able to insert a stent right into that artery and use the balloon to open up that artery. So we call this an angioplasty with a stent placement. And so you'll see there's the stent placement, and we've placed it, and we removed the apparatus. All right, so do you remember we were talking, if you go back to, I think it's slide 8 or 9, we had acute coronary syndrome. And that was really critical that we differentiated like an acute MI or a STEMI with acute coronary syndrome, where we had unstable angina and non-STEMI, right? So your cardiogram would not show ST wave elevation, but your enzymes would show elevated troponin. So how are we going to treat acute coronary syndrome? Important we look at drugs. Some of you have asked, you need to know the names. Most drugs, I'm not going to worry about names. There's some that are simple, like morphine. I don't want you to say we give an opioid, because we're actually going to give morphine. So the name of the drug is the name of the drug. We're going to give nitroglycerin when we have acute coronary syndrome, but we're not giving it under the tongue, not as a spray or not as a patch, which is long-term use. We're going to give intravenous nitroglycerin. Now, we might give you a spray until I get an IV started and we get that going. But the point is that you're moving to give IV nitroglycerin. We have much better control. It's much more powerful. Beta blockers, and do you remember beta blockers decrease that workload of the heart by decreasing the heart, or keeping the heart rate within a very stable range, and making sure that there is enough time in diastole for those blood vessels to the cardiac arteries to fill themselves so they can exchange what oxygen is possible, and also decrease that workload of the heart by not making it pump as hard. We're going to use ACE inhibitors. We talked about that. We're going to use, do you remember we talked about the real risk when you have an MI or other things in ACS, we're going to see those dysrhythmias as well. So many kinds of antidysrhythmic drugs depending on the rhythm. So again, you don't need to know all the names of those because it's depending on the rhythm. We're going to look at cholesterol lowering drugs. Are you doing that in the ER? No. But in long term, we need to look at your cholesterol, and if it's appropriate, make sure we've managed that. And remember, there were lots of ups and downs about those. Do I need you to know the names of those cholesterol lowering drugs? No. Stool softener, remember, and you don't need to know the name. Typically, we're going to see colace or the generic name Ducasate. That is essential because we don't want a person to strain to go to the bathroom, because straining often causes that vagal response and the person will faint or even go into a dysrhythmia. Okay, now do you remember we talked about chronic stable angina? Now the difference between stable angina and unstable angina is something you should just in your own head know. Stable angina, it is predictable, right? So it's really important that we recognize what that looks like, and when we have stable angina, how a person can take part in health teaching activities to enable them to return to life as much as possible in the way that that makes them happy to live. Versus unstable angina, which is unpredictable, which can happen in your sleep or can happen at rest and other things. Stable angina, typically there's an eliciting event that we can identify. So acute intervention would be really important in terms of pain. How do we respond to that pain? We're gonna, use medications. We're going to, so we could use nitroglycerin. We could give morphine and other things. We put somebody on a cardiac monitor immediately. Why would we want to do that? Because it's essential that we have an understanding of what's happening with the rhythm. Somebody might be having angina, or they might be moving to a different kind of process, but important that we recognize what that looks like on a cardiac monitor, but also that we keep vigilant in our monitoring of that patient. We want to keep them as much as possible comfortable. And that's because all of us are nervous at some change in our health. But in particular, when we're worried that we're having chest pain, it's really anxiety provoking. And so we want to both relieve that stress and anxiety and allow the patient to rest. And as they're able to rest and be pain-free, they're able to feel more comfortable, but also your body is able to more efficiently use the oxygen that is forming. Your blood pressure is able to come down, and your heart is pumping against less resistance. We're also going to try to understand how they're feeling about this. It's pretty traumatic for lots of people, the diagnosis or living with a change like this. So how are they experiencing this? How does this impact their daily life? What do they think about themselves and how they will move forward, things like that. Really important as we're talking about client teaching. Often one of the responses we see is fear associated with this change, with this diagnosis of angina, that we talk about physical activity and the resumption of physical activity, and that they would move through a process of resuming physical activity, and in particular that idea of resuming sexual activity, and that many people think that once they've developed a heart condition, they may not be able to return to previous levels of activity. That is not accurate, but we need to move forward in a way that is safe and stable. Same thing for sexual activity, that if a patient thinks they can never resume sexual activity, we really want to have an open conversation about what their life is like. Anyways, they might say, well, I haven't had sex in 20 years, so it doesn't matter. Or they may say that was an important part of my life. However it goes, we would give them important information that just as you can resume other kinds of physical activity, you can resume sexual activity. And usually that benchmark is, you can tell when you're ready to resume sexual activity, when you're able to do certain physical things, climb a couple of flights of stairs, things like that. Okay, so do you remember, we talked a little bit about this a second ago, coronary artery bypass graft surgery, the cabbage surgery. And that is where they take a vessel from your leg, and they put that, they actually attach that within your heart, so that you create a different pathway for blood circulation. And we do this when, let's say, for example, we've given you a clot buster, we've given you other medications, we're not able to get a significant enough improvement in that area, we're not able to get significant enough blood flow in the absence of this. If someone has a left main coronary artery or 3-vessel disease, we do this surgery because if that is blocked or occluded, the person really has nothing left to protect that left ventricle, right? And so that left ventricle is so essential. Remember, that's the powerhouse, that's the pumping powerhouse. So we really work very hard to protect it as much as we can. For patients who are not candidates for PCI, so for example, that, where we're inserting that stent, let's say you've got quite a long lesion, or your lesion is just too hard to get to, that blockage is just too hard to get to, we may actually have to do a cabbage instead. Or if we've actually done inserted a stent, previously done a PCI, and you're still having ongoing chest pain. So it's been unsuccessful. We may have to move on to do a CABG. Oh my gosh, look at this. So in a CABG, we see that a segment of that saphenous vein is removed from our upper thigh, and then we're going to place it in our heart and create that alternate pathway. It's quite a remarkable surgery. It's hard to believe that human beings have come up with this level of technology, but that we're able to do this and create that alternate pathway for blood circulation to nourish our heart. Oh my gosh. Moving on to an incredibly exciting topic, because every one of you, if you have not already, will have a patient with heart failure. Risk factors for heart failure, coronary artery disease. That's how we started the class, right? We're talking about coronary artery disease, and we finish off with heart failure. Hypertension. Hypertension is the enemy of your heart because your heart has to pump against that really powerful resistance. Kinds of risk factors that may influence it, go back to that list for coronary artery disease, and this will sound familiar. Diabetes, tobacco use, obesity, high cholesterol. It's all kind of remarkable. Here's a case study. I'm not really going to go into it too much, but imagine this 68-year-old woman admitted to the hospital for shortness of breath. She was diagnosed 4 years ago with heart failure after failing to follow the recommended medical regimen for an MI she suffered a couple of years prior. And so it's that idea, if you're supposed to follow a medical regimen that might have included antihypertensives or other things, in failing to follow up with that regimen, she may have created conditions where her heart actually was continued to be damaged, and she experienced heart failure. She states that she was taking a diuretic but ran out 4 days ago and has not been able to refill her prescription, and that she noticed some swelling in her feet that seemed worse than usual. Sounds a little ominous, doesn't it? And if I forget to tell you the story here, I'll tell you the story in class of a very, very sad situation I had with a person with heart failure. On physical exam, here we have, she's alert and oriented to person, place, and time. Fine crackles in her bilateral lower lung lobes. And what do fine crackles tell us? There's some fluid there, right? She's got shortness of breath on minimal exertion. And we always want to watch that work of breathing. So on minimal exertion, she becomes quite winded. Her O2 sat is 89%. Her blood pressure is 165/92. On room air, her O2 sat is 89 on room air. Blood pressure is 165/92. What do you think of that? Yeah, hypertensive. Heart rate a little bit tacky at 110. Respiratory rate at 24. What do you think? Yeah, tachypnic. She's got S1 and S2 sounds. Remember, that's lub-dub, without a murmur, no extra heart sounds. Capillary refill is sluggish in her lower extremities, but normal in her upper extremities. And she's got 2+ edema, bilateral in her lower extremities. Now, how do we count that 2+ edema? It is imperfect, an imperfect scale, but you're going to push in with your finger and you're going to see that edema. So thinking about our patient, what do we know about heart failure? Heart failure is an abnormal condition, and that really at the core of heart failure is this impaired cardiac pumping and filling. So impaired pumping of that heart, being able to pump the blood out either to our lungs or to our central circulation, or difficulty getting that blood back in filling our atria. So because of this difficulty in pumping and filling, the heart is not able to produce an adequate, what's called cardiac output, right? So we're not able to pump enough blood out to meet the metabolic needs of our body, right? And there's all kinds of cardiovascular diseases, if you remember, that are associated with heart failure, including, remember, high blood pressure. And you see how that would this constant chronic high blood pressure, the difficulty of the heart trying to pump against that resistance, could lead to the inability of the heart to continue pumping effectively against it. Coronary artery disease and MI. So MI, where we have an injury to the heart and the heart is not able to pump adequately to be able to meet, to get a good enough cardiac output to meet the metabolic needs of the body. What we know is that we're making really good progress on a lot of other cardiac diseases, even MI and all kinds of new development of new medications for heart dysrhythmias. Where we are struggling is with the incidence of heart failure. It's actually on the rise, likely because we've made such good progress in other areas, such as MI. People are living longer and they're living with injuries they might otherwise have previously died from. And so they have hearts that are at higher risk, and then there's subsequent heart failure. Important to recognize how serious this is. that there's pretty significant numbers in both morbidity, so disease rate, and mortality, so death rates. And about a third of people with heart failure will be dead within a year. So a third of people diagnosed with heart failure today will be dead within a year. And about 50% of people diagnosed with heart failure today will be readmitted to the hospital within a year. So pretty significant mortality and morbidity. So let's talk about these clinical manifestations. So heart failure with reduced ejection fraction. Ejection fraction is how much we are pumping out. And so this is caused by an inability of the heart to contract effectively. So for example, we had that MI, that area of the heart, let's say our left ventricle is damaged with that MI. Because of that, remember we said the heart is not as compliant, even if we've recovered a little bit from the MI. And so it's not able to pump, to really contract, fill effectively and contract effectively. We've got increased afterload. So the afterload is we're trying to pump against that pressure in the peripheral circulation system. Cardiomyopathy, so there's an actual pathological process within the heart. So the heart muscle has a pathology. The heart muscle is not pumping effectively. And mechanical abnormalities that we might have been born with or that might be caused by disease. And so if we have valvular disease and other things. So what do we usually see when we're talking about heart failure? Orthopnea. And do you remember what that is? So orthopnea is shortness of breath when we're lying down. And that's very characteristic because one of the things we do when somebody is short of breath is we put them in that high Fowler's position to be able to expand their thoracic cage and be able to get a full breath. So orthopnea, shortness of breath when lying down. Dyspnea, which is just shortness of breath, difficulty breathing, and tachypnea, so a rapid respiratory rate. Use of all those accessory muscles. And it's important to remember the difference between children and adult. We're not going to talk about children, but for adults, we're going to see use of accessory muscles up here. We're raising our shoulders when we're breathing. We're using our abdominal muscles and those muscles along our ribs. We're flaring our noses even, all of those accessory muscles to help us. As we're seeing very significant disease process, we may see cyanosis, quite a late symptom. And that cool and clammy skin, right? Because we're having a difficult time breathing, we're getting inadequate oxygenation, that cool and clammy skin. Carrying on, when we do some physical exam, we might see that a person has a cough with frothy or blood-tinged sputum. That's a really important sign. That's moving along in a very significant way with heart failure to potentially even pulmonary edema. When we listen to their lungs, remember we're going to listen at the front and at the back. We're going to hear crackles, particularly in the bases, but they may be moving upward. Fine crackles are a sign of less fluid. Really coarse crackles tell us there's a lot more fluid there. We may hear wheezes as well, just because the airways are so impacted by this disease process. Tachycardia, because remember, we're impacted by this decrease in oxygenation. Our heart is pumping harder to try to move that fluid around as much as we can to get whatever oxygen we have around to our cells and in our heart and to our cardiac circulation system. And also we can see either a drop in blood pressure or a rise in blood pressure. So we can see hypotension or hypertension. Yikes, look at this, wow. Okay, let's start at the top and get ourselves down because we're trying to figure out what this looks like, right? Suspected heart failure. Let's look at the symptoms, and we already talked about these, right? Clinical history, so we look at your symptoms, your limitations in life, your prior disease, your risk factors, what other conditions or exacerbating things are going on. If you have any other, if you've been taking any drugs. Physical exam, we're going to look at vital signs, your weight, and the reason we're looking at your weight is not to be not to fat shame you, as my daughter likes to tell me, but instead to look at if there's a change, an increase or a decrease in your weight. In particular, we're going to talk about that with sudden increases in weight. Volume status. So are you dry? Are you fluid overloaded? Things like that. Going to listen to your heart and all of those heart sounds. We're going to listen to your lungs. We're going to check your abdomen and look at your vascular system. So initial investigations, we're going to look at it, do a chest x-ray. Why? What are we looking for? We're looking to see if we can see fluid in your lungs, and we're going to be able to see that very effectively. We get the x-ray back right away. We're going to do a 12-lead ECG. Why? Because we want to determine what may be causing this heart failure. There's a heart failure can be caused as a result of an MI. It can be caused as a result of pericarditis or something else. So we want to see what the electrocardiogram tells us. We're going to do a variety of blood work. This B-type natriuretic peptide is actually done at Lake Ridge Health, so it's an important thing to note because one of our local hospitals does it, but not all hospitals do it. We're going to do some basic blood work, CBC, electrolytes, look at your kidney function, look at your glucose, which is standard, and look at your thyroid. Thyroid function and cardiac disease are well associated. So if all of those turn out normal, then we're thinking, I'm not really on the movement towards seeing anything that looks like heart failure. Abnormal, again, we're still moving down the positive line. Next thing we're going to do is look at ventricular function, and we do that with an echocardiogram. An echocardiogram is an ultrasound of your heart, and that looks at cardiac function, right? It looks at the ability of your heart to actually contract, and you can see that blood moving through your heart. So that actual contraction of the muscle of your heart. So we're going to do that ultrasound of your heart in an echocardiogram, and we're going to look at whether, again, is that normal or is it abnormal? And then there may be additional diagnostic things we'll want to do. Cardiac catheterization even, some other exercise stress testing, a CT scan, other things. But often at this point, we've got our diagnosis. And remember, all along this side, if we see positive things from all of our investigations here, we're going to move down that line towards heart failure. If all of these are ruled out, then something is going on, but it's not heart failure. So let's talk about left-sided and right-sided heart failure. Now, left-sided heart failure actually leads to right-sided heart failure. So it's a little bit of a loop all over the place, and let me just try to go through it. Let's start here. Where is a good place to start? Okay, let's start right up at that purple box. Increased systemic vascular resistance. So what does that mean? Remember, we've got that systemic vascular resistance, the tone in your systemic blood vessels increases, and so your heart is having to push hard, contract, and really in a very forceful way to try to get that blood flow through. So increased systemic vascular resistance. Then that leads to the increased force of your left ventricular contraction, right? Your left ventricle has to pump really hard, contract really hard to get that blood flow through. Because of that, that left ventricle actually needs more oxygen. It's working so hard, it needs more oxygen. So we've got increased oxygen demand. Because there's that increased oxygen demand of that left ventricle, remember that's the powerhouse of the heart, we have left ventricular hypoxia. And I'm going to stop there just for a second because we're going on a little loop just for a second. So if we look to the left, because we have that left ventricle hypoxia, that often leads to a drop in blood pressure. And I'm going to go upwards first. So we've got that drop in blood pressure, which leads to the release of norepinephrine and epinephrine. Our body does that to try to rescue us. But you know what happens when we release norepinephrine and epinephrine? The force of our left ventricular contraction increases. Now remember, the left ventricle is having to contract really forcefully to try to push blood against that resistance. So the oxygen demand went up, so we became hypoxic. And then the blood pressure dropped. Now we've released these chemicals, and it's forcing the heart to pump even with a greater contraction. You see how it's like a cycle that's not very effective? Norepinephrine and epinephrine also lead to peripheral artery constriction because we release those, let's say, when we go into shock and other kinds of things. And so because of that peripheral artery constriction, that increases our systemic vascular resistance, another loop. So we're back where we started. That's a loop that's going around. It's not a great loop, it's a pathological loop. I'm still going to take us back down on the left side here. Remember, we had the left ventricle hypoxia. On the right side, it led over here to the decrease in systemic blood pressure. Let's go down for a second. Two things are going to happen, two columns. Because we have a drop in our blood pressure, we're going to have decreased blood flow to our kidneys. When we have decreased blood flow to our kidneys, we activate the renin, angiotensin, aldosterone system, and that leads to sodium and water retention, right? Our body thinks I don't have enough fluid, sodium and water retention. We also, at the same time, have an increase in antidiuretic hormone, which also leads to sodium and water retention. So we've got two pathways coming together to increase sodium and water retention, and sodium and water retention lead to peripheral edema. Now we're going right back up to where we're still at the heart. We've got that left ventricular hypoxia. And because that left ventricle is working so hard, it needs more oxygen. It's not getting enough oxygen. Because it's not getting enough oxygen, the force of that contraction decreases. When it's not getting enough oxygen, like you, when you run a marathon and you're not getting enough oxygen, you have to stop running. right? Or slow down because you're just not getting enough oxygen. So the force of that contraction decreases. And then we end up with an increase in the left ventricular end diastolic pressure, leads to an increase in the left ventricular preload, right? So the preload means in that left ventricle, the amount of fluid that we're able to get into that ventricle is decreasing. And so we have an increase in the, because we can't get the blood to exit the left ventricle, we have an increase in the preload of the blood entering the left atria. So now the left ventricle can't eject its blood, so the left atria can't deposit its blood into the left ventricle. So there's increased preload, a backup into the left atria. And because we have that backup into the left atria, what we end up with is pulmonary edema. So on the left column, we ended up with peripheral edema. On this right column, because of this preload issue, we now have pulmonary edema. And when we have that pulmonary edema, we have increased pulmonary vascular resistance. So before we had systemic vascular resistance, that increased pressure. Now we have that increased pressure in our pulmonary vasculature, which leads to right ventricular failure. And right ventricular failure is a real problem. Now we've got our left ventricle, which is the powerhouse, and the right ventricle now is in failure, and increase in the right ventricular preload. So all in all, this is a cascade, and just take your time working your way through that, but it is a cascade of events that leads to very significant cardiac pathology. And let's just talk about them now a little bit in terms of what we see left heart failure and right heart failure. So right heart failure, you're going to be thinking peripheral signs. So it's that congestion of blood flow to peripheral tissues. We see that dependent edema, so in our feet, legs, and also sometimes ascites. So that's where we have that fluid accumulating in our abdomen. Part of that happens because we can have actually congestion in blood flow to our liver. We also have congestion in blood flow within our GI tract, and signs that would be related to both that and impaired liver function. That leads to a loss of appetite, GI symptoms, and actually sometimes you have weight loss associated with that GI system issue. We also, though, are always keeping our eye out for weight gain that is related to sudden increase in heart failure. Left heart failure, we see symptoms related to our lungs. So left heart failure, we see a decrease in that cardiac output. Remember, the left ventricle is that pump. So decrease in cardiac output. We see that congestion in our lungs where we're seeing crackles and wheezes. With that decreased cardiac output, that's where we get winded. When our heart is not pumping effectively and we are not able to pump around enough blood to provide adequate oxygenation to our tissues, we see that activity intolerance, right? And that's related to that tissue perfusion, lack of tissue perfusion. When we're looking at pulmonary congestion, that's poor gas exchange, and we're going to see things like cyanosis or signs of hypoxia. We're going to see decreased O2 sat or increased work of breathing. We're also going to see a cough with that frothy sputum that we talked about, sometimes blood tinged. Orthopnea, that inability to lie flat, shortness of breath when lying flat. And paroxysmal nocturnal dyspnea, which is interesting. It's that at nighttime is when you may feel fine all through the day because you're sitting up, moving around. When you go to bed, a couple of hours after you go to bed, you're waking up incredibly short of breath because that fluid has returned with your lungs. So how are we going to manage this patient? It's really important that we recognize how to position a patient, importantly for maximal oxygen intake, and that would be high Fowler's position. High Fowler's position is important for a couple of reasons. One, it decreases venous return. So because you're sitting up and your heart has to pump that blood against gravity, you're not going to, it helps to decrease that so that you've got, because of that pooling of blood in your periphery. And also because it opens up the thoracic cavity, you're really able to allow for that better ventilation. Supplemental oxygen is critical. I know you often see or hear about providing 2 liters of oxygen. We provide enough oxygen, adequate oxygen, until we're able to get the patient to an appropriate O2 sat level or to take some ABGs that will tell us about that. We're going to put the person on a continuous heart monitor. so that we know what's happening. We would do a 12-lead EKG, but put them on a continuous heart monitor. And also we're going to provide medications, and there's a variety of different kinds of diuretics that we can use. Most often, again, in an acute phase, we would be using something like Lasix. In a long-term phase, we may be looking at something different. If you're going to ask me, am I going to ask you to memorize which diuretic is most helpful at this point? No, I want you to understand that it's important that we give patients medications that are going to help them to pass the fluid that they've been collecting, and we want to get to a dry state for patients. Oh my gosh. Can you believe we're at the end? Let's talk about our patient. What is the priority of care for her? Do you remember? She's 68 years old. She came in with symptoms of congestive heart failure after not following up on her post-MI instructions. She is ordered a diuretic, but hadn't taken it for 4 days because she said she couldn't get it filled. What do we need to do? Number one, we need to do all of that assessment, put her on a monitor, determine if she's got congestive heart failure. If she does, our focus is going to be providing her with medications like a diuretic to get her to get that fluid out, so that she's able to pass enough fluid that the problem, whether it's left heart failure or right heart failure, is corrected. We want to decrease the amount of circulating volume, right? She's in fluid volume overload. We're going to do really pristine in and out monitoring to make sure that we know where she's at with her fluid state. We may even start doing daily weights as well as in and out monitoring. We're going to assess and reassess her respiratory status constantly, and we're going to make sure that we're checking her cardiac system pristinely. We're going to look at oxygen saturation. We're going to listen to her lungs. We're going to see if her respiratory rate comes down to normal or closer to normal. We're going to look at her capillary refill and see if that's improving. We're going to assess for peripheral edema and see if that's improving. We're going to take those daily weights. We're going to look at an input and output. We're going to check her lungs to see if they sound like there's less congestion. What measures would the nurse use to prevent a reoccurrence? We're going to teach her about the importance of adhering to her medication regimen. It's really critical, and also seeking help as needed. And I'll give you a really sad story. A patient I looked after post-mortem in the ER. She was a really lovely lady, although I never got to meet her while she was alive. She and a couple of her friends decided to go on a road trip. So I think there were 3 other older women and her. She was about 70 years old. Decided to go on a road trip. They were going to drive across 5 states in 5 days and just have a really great time together. And she thought, you know what, I don't want to be a downer on this trip, and I take a water pill every day, but it makes me go to the bathroom all day long, and we're only going to be gone for 5 days, 5 states in 5 days. So I'm just gonna not take my water pill because we're in the car all day. I don't want them to stop in the car all the time. And after a couple of days, after the second day, she was not feeling all that well. She was developed a little bit of a cough, but they hadn't really put much to it. The third day, they stopped at a gas station. Everybody got out to go to the bathroom. They thought she was sleeping. They went to check on her, and she had died. This lady had decided not to take her significant diuretic for the entire trip. By day 3, she'd had a cardiac event, had gone into flash pulmonary edema, and had died in the backseat of that car with her lovely friends all there. And you know, so it's important to recognize the reasons why people might be non-adherent to their medication regimen. It's not that she thought she knew better. It's not that she thought it wasn't important. She just wanted to have this time. And I think it was that health teaching was really missing in terms of how important it was and the risks that are associated with not following that regimen. Anyways, I hope you found this helpful. Gosh, it's a lot of fun for me. I really love to talk about this stuff, and I hope you like to listen. So I'll see you soon. Thanks again. Bye.